and sternoclavicular joints, separations and sprains by Caleb Deaver. The anatomy of these are obviously the acromioclavicular joint, and that is where the acromion and the clavicle articulate, and is kept in place by the acromioclavicular ligament, as you can see in the figure I put in this slideshow. The other aspect of this presentation is the sternoclavicular joint, and that's where the arm attaches to the trunk of the body. This is the only place the arm attaches to the rest of the body. It's surrounded by both cartilage and sternoclavicular ligaments. Pathology. A sternoclavicular separation is characterized by 3 grades, and these are listed in the slides. Grade 1 is a slight displacement of the joint. It might be partially torn or stretched, as you can see in the figure below. Not very serious, usually very treatable. Grade 2, a partial dislocation of the joint in which there might be some displacement, may not be too obvious during the examination. You would likely refer this patient out to get x-rayed or MRI'd. Once again, not very serious, but definitely should be referred out. Grade 3 is the complete separation of the joint. The coracocavicular ligaments have been completely torn, usually displaced and very obvious, and once again should be referred out immediately. Should see this almost automatically as soon as the patient comes through the training room door or is lying on the field. Pathology. The sternoclavicular sprain is also put into 3 grades. Grade 1. The tears in the joint ligament is very mild and microscopic, very, very minute, causes some discomfort with motion and activity, nothing serious. Maybe an activity modification would solve this. Grade 2. Ligaments between the collarbone and sternum are visibly torn, but ligaments between the collarbone and ribs remain intact. This is getting a little bit more serious and should be paid attention to more so than the grade 1, and should be treated a little bit more serious in the grade 1 and probably referred out. Grade 3. All ligaments sustain severe damage, which this is not good at all. A lot of tearing, some deformation by dislocation. It's obviously not in its normal position if it's dislocated or deformed. Just like the separation, it should be very, very obvious. Acromioclavicular separations are also separated into 3 grades. All of these injuries are separated into 3 grades. Grade 1, mild shoulder separation. This involves a sprain in the AC ligament that does not move the collarbone and looks normal on x-rays. So obviously it's not that serious. Will cause discomfort in activity and movement. Should be treated, but is not that serious. Grade 2, a tear in the AC ligament or a sprain or slight tear in the coracoclavicular. Obviously serious, and it is very obvious on presentation and an examination with the visible bump. You can see on the slide that it is starting to tear. That will be very obvious with point tenderness as well as the visual bump. Grade 3 is the most severe shoulder separation. This completely tears both the acromioclavicular and the coracoclavicular ligaments. Very, 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 very obvious and should be referred out immediately. Very obvious on field and in the clinic. Like I said, should be referred out for testing and to a physician. Pathology. As I said before, all of these injuries are classed into 3 grades. Grade 1 for the acromioclavicular sprain involves stretching and spraining of the joint capsule. No real damage. Not serious, much like the other grade 1. Should be treated, but just very mild discomfort. Grade 2 involves tearing of the joint capsule, stretching, but not tearing of the ligaments. As you can see on the picture, there is some tearing of the joint capsule, but not the ligaments. Moving into a more serious nature here, should be referred out, should present point tenderness as well as tenderness when performing activity. And grade 3 obviously involves tearing of the joint capsule as well as the ligaments, even to the fact that the clavicle tears through the fascia above it. So obviously some residual pain here, some referred pain up the shoulder. Very serious, and pain typically lasts 1 or 2 months and is probably chronic, if not intervened with surgery. Mechanism of injury. The sternoclavicular separation and sprains are caused when a patient is struck on the back, aka a sandwich mechanism. That is when an athlete lands on the ground and someone comes behind him and lands on top of him, forcing his chest into the ground, making him or her sternoclavicular joint sprain or separated. The most common mechanism of injury of acromioclavicular separation and sprains is falling on the tip of the shoulder, as well as taking a blow to the tip of the shoulder, way more common than a sternoclavicular injury, and also maybe less serious on a lot of occasions. Also, fooshing is a very common mode of injury. Signs and symptoms for the sternoclavicular sprain and separation is pain, swelling, warmth, deformity, as you can see on the picture. A lot of what you would think a joint injury would present. One thing that I thought was very interesting is the difficulty breathing, and that also plays into a differential diagnosis, which is ribs dislocating or ribs breaking. But once again, you will see the point tenderness on the sternoclavicular joint and not on the ribs. Signs and symptoms for acromioclavicular separation and sprain. Pain, swelling, warmth, deformity, popping with movement. Obviously, point tenderness at the tip of the shoulder, which is right above the tip, not really at the tip. A lot of similar signs and symptoms here, but obviously different locations to really be specific to the acromioclavicular. Special tests for the acromioclavicular: cross-body adduction. The patient elevates the arm, and then we go in and adduct the arm. And this basically focuses on that impingement and that pain. Another test would be taking the patient's arms to the side and pulling down on them and seeing if there is pain with that motion. That also rules out acromioclavicular pain, as well as the tap test. And then the tapping of the acromioclavicular joint to check for point tenderness. Like I said, at the tip of the shoulder, a little bit above, is where you would want to tap to see if there is point tenderness. And for sternoclavicular, there's a special test for it where you grab the collarbone and wiggle it up and down and see if there is pain in that area, as well as taking the patient through passive and active ranges of motion to both actively see if there is pain. And honestly, the best way to check for a sprain or a separation is CT scan and x-ray to get that detailed picture if both the range of motion and the wiggle test prove to be positive. Predisposing factors. Obesity, obviously landing on your shoulder with more force and more weight will cause you to more likely injure that. Contact sports, as in football, with the sandwich mechanism that would come, you would only see that in most contact sports. Motorsports, crashing and hitting inside your car obviously would cause shoulder issues and arthritis. Recognition and differential diagnosis. Recognition is very obvious with acromioclavicular, with the point tenderness, and the just pain in general is very specific to that joint. The giveaway is the deformity at the joint as well as the swelling, but more than likely it will be a lot of point tenderness on that joint. Differential diagnosis for this is a humeral head fracture, arthritis, rotator cuff tears since they're in that general area, clavicle fracture, once again right on that area, and also a clavicular avulsion fracture. Recognition and differential diagnosis for the sternoclavicular joint is mostly due through pain and palpation. Not a whole lot to see, but if it's serious enough, there will be obvious deformity, but no really obvious presentation if the patient has not done something serious to that joint. You'll most likely need special testing with the CT and X-ray scan to see definitely if that's what the athlete is suffering from. Some differential diagnosis of the sternoclavicular is a rib fracture, dislocation, sternum fracture, clavicle fracture, and what I thought was neat is infection. Obviously, any structures near that, which there is a lot, is going to be a differential diagnosis. One way to rule out these are with tests that you order with X-rays and CT scans. Very hard to differentiate between the two, both palpating and not, because the first rib, as you see on the picture, sits directly below the clavicle, so it's hard to rule out. Management and treatment, resting, ice, immobilization, NSAIDs, and I think the most effective way to treat is activity modification, and that's taking the overhead movements out of a practice or a lifting session to better rest that joint and ligaments to take the swelling down. If an AC injury is not treated correctly, there is the Mumford procedure, which I thought was very interesting, when you just cut off the distal end of the clavicle to relieve pain. I thought this was very interesting and very, very abrasive to completely cut off the end of the clavicle. Referral and immobilization. A brace can be worn to stabilize the sternoclavicular joint, as well as a brace with a donut pad for the acromioclavicular joint. Now, some of these can be useful, but are not very useful with the sternoclavicular, but very useful for the acromioclavicular joint. As I've said previously, referral to an orthopedic surgeon should be made for special tests such as X-rays or CT scans to confirm your diagnosis. If this is a grade 2 moving into a grade 3, grade 1 is very, very manageable. Prevention, use proper fitting equipment such as shoulder pads. Make sure they are covering up both the acromioclavicular and the sternoclavicular joint. Maintain a healthy weight, therefore reducing the weight that you're falling on, and learn how to fall without fooshing. Learning how to fall is a very, very key mechanic, and just living in general. That way you do not break an arm, dislocate joints, or in this case, hurt your acromioclavicular or sternoclavicular joint. Mulligan technique. There is no mulligan technique for these because there is no real range of motion for these joints. They're pretty inactive joints in terms of range of motion. Here's my PCOT, very interesting PCOT. And then my references without any .coms and very, very up to date. I think they're all in 2020. That is all. Thank you for viewing this video, and have a good day.